I am Dr. AhmedZeeshan, and today's my topic of discussion is management of tuberculosis. What will be the topics under our discussion? These include introduction, diagnostic tools for pulmonary tuberculosis, pulmonary TB treatment, tuberculosis and pregnancy, tuberculosis and liver disorders, tuberculosis and renal disorders, tuberculosis and HIV. Tuberculosis is caused by Mycobacterium tuberculosis and it most often affects the lungs. TB spreads through the air when people with the lung TB cough, sneeze or spit. A person needs to inhale only few germs to become infected. Pakistan ranks the 5th highest among the TB burden countries and at a rank of 6th among the multi-drug resistant tuberculosis. What are the anti-tuberculosis therapy drugs? First-line anti-tuberculosis drugs include isoniazid, rifampicin, ethambutol, pyrazinamide and streptomycin. Whereas second-line anti-TB drugs, they are divided into two groups. Fluoroquinolones include levofloxacin, moxifloxacin, ciprofloxacin. Ofloxacin is no longer used. And injectable ATT drugs include kanamycin, amikacin and capreomycin. These are the dosage of these first-line ATT drugs, which includes isoniazid is 4 to 6 mg per kg once daily, and for a weight of more than 70 kg it becomes 300 mg. Whereas rifampicin is 8 to 12 mg per kg once daily, and it is 600 mg for a more than 70 kg adult weight. Pyrazinamide is 20 to 30 mg per kg. Ethambutol is 15 to 25 mg per kg once daily. Rifabutin is 5 to 10 mg per kg once daily. These are the first line drugs, which this is a mnemonic which we use often to remember these first line drugs, to remember them according to their dose on weight. Mnemonic is given below: IRESP, I for isoniazid 5 mg, R for rifampicin 10 mg, ethambutol for 15 to 25 mg per kg. Pyrazinamide is given in 25 to 35 mg per kg. Streptomycin is 15 to 20 mg per kg. These are the adverse effects discussed of the ATT drugs. Isoniazid include hepatotoxicity, peripheral neuritis, hypersensitive reactions and drug-induced lupus. Rifampicin is having hepatotoxicity, gastrointestinal autoimmune reactions, thrombocytopenias, acute hemolytic anemia. Pyrazinamide is very hepatotoxic. This is the most hepatotoxic drug among the ATTs. Other include hyperuricemia, gastrointestinal and allergic reactions. Ethambutol causes optic neuritis, color blindness, allergic reactions and hyperuricemia. Streptomycin causes vestibular dysfunction, deafness, nephrotoxicity, neuromuscular blockage and peripheral neuritis. I want to mention here one very important thing. Whenever we are prescribing ATT to a newly married couple or someone who is on oral contraceptive pills, you have to counsel them that the effect of OCPs will be diminished when you are taking ATT and the patient will be at verge of having pregnancy. So kindly mention it. What are the diagnostic tests? They include baseline tests, full blood count, CRPs, ESRs, LFTs, sputum containing microscopy, AFB tuberculin skin test, AFB smear microscopy, nucleic acid amplification or gene expert or line probe assays, pleural fluid ADA levels, culture, solid media is used, liquid media, and we can use chest X-ray and CT chest ultrasound. Management of tuberculosis. We have categorized the patients of tuberculosis into 3 different categories. Number 1 is new cases, number 2 is retreatment cases and retreatment failure. The duration of chemotherapy is 6 months. 2 months is intensive phase and 4 months is maintenance phase. However, it is 8 months for retreatment cases. Duration and regime for patients who have failed the treatment regime depends on the culture and sensitivity report. New cases are defined as who have never received treatment for tuberculosis or taken it for less than 1 month. This group includes smear positive tuberculosis and smear negative tuberculosis and other extrapulmonary tuberculosis. The treatment of this group patients should be 6 months short course of chemotherapy. Initial intensive phase includes 4 drugs: isoniazid, rifampicin, pyrazinamide, ethambutol. They are given under dot therapy for 2 months, and for continuation phase we give isoniazid, rifampicin and ethambutol daily for 4 months. Pyrazinamide is stopped. Retreatment cases. The recommended treatment for this group of patients is 8 months as follows. Initial intensive phase includes rifampicin, isoniazid, pyrazinamide and ethambutol for 3 months. Continuation phase includes rifampicin, isoniazid and ethambutol for a period of 5 months. If rifampicin resistance is present, then these patients are referred to PMDT unit for further drug susceptibility testing and treated as MDR cases. All smear positive cases identified as failures, that is the treatment after loss to follow-up, and relapses should be classified as retreatment cases. In patients who have had treatment interruption, the reason for interruption must be sought out, such as medication stockouts, adverse effects from the medicines, or need for greater patient-provider education should be addressed. Pregnancy and the breastfeeding, very important point. Women of childbearing age should be asked about current or planned pregnancy before the starting treatment of ATT. A pregnant woman should be advised that the successful treatment of TB with a standard regime is important for successful outcome of pregnancy. With the exemption of streptomycin, the first-line ATT drugs are safe for use in pregnancy. Streptomycin is ototoxic to the fetus and not be used during the pregnancy. If mother is sputum smear positive at birth, the newborn should be evaluated for active TB by X-ray, gastric aspirate. If active disease is diagnosed, child should receive full therapy. If active disease is ruled out, give isoniazid prophylaxis to newborn for 3 months and repeat Montauk's test. If Montauk's test is positive and active disease is ruled out, a total of 6 months prophylaxis with isoniazid should be given. Pyridoxine supplementation is recommended for all pregnant or breastfeeding women taking isoniazid if Montauk's test is negative. Isoniazid should be stopped and child must be given BCG vaccination. Breastfeeding should not be discouraged for women being treated with first-line ATT because small concentrations of these drugs in the breast milk do not produce toxicity in the nursing newborn. Conversely, drugs which are excreted in the breast milk should not be considered an effective treatment option of tuberculosis or for latent tuberculosis infection. In case of a drug-resistant TB, if mother is sputum smear positive, the care of the infant should be left to the family members until she becomes smear negative. If this is not practically feasible, the mother and infant are together. This time should be spent in a well-ventilated areas or outdoors. The mother should use a surgical mask until she becomes sputum smear negative. Liver disorders. Thus, this section covers the tuberculosis treatment in patients with pre-existing liver disease for detection and management of hepatitis induced by ATT drugs. Patients with the following conditions can receive the usual tuberculosis regime provided that there is no clinical evidence of CLD. Hepatitis virus carriage, a past history of acute hepatitis, a current excessive alcohol consumption. However, hepatotoxic reactions to the anti-tuberculosis drugs may be more common among the patients and should therefore be anticipated. ATT in diagnosed liver diseases. In patients with unstable or advanced liver disease, liver function tests should be done at the start of the treatment. If the serum alanine aminotransferase level is more than 3 times the normal before the initiation of the treatment, the following regimes should be considered. The more unstable or severe the liver disease is, the fewer hepatotoxic drugs should be used. Possible regimes: 2 hepatotoxic drugs rather than the 3 in the standard regime. 9 months of isoniazid and rifampicin plus ethambutol until or unless isoniazid susceptibility is documented. 2 months of isoniazid, rifampicin, streptomycin and ethambutol followed by 6 months of isoniazid and rifampicin. 6 to 9 months of rifampicin, pyrazinamide and ethambutol. 1 hepatotoxic drug, 2 months of isoniazid, ethambutol and streptomycin followed by 10 months of isoniazid and ethambutol. No hepatotoxic drugs must be given. 18 to 24 months of streptomycin, ethambutol and fluoroquinolones. Clinical monitoring, that is a liver function test if possible of all the patients with pre-existing liver disease, should be performed during the treatment. Use of ATT in chronic liver disease, which is Child-Pugh score, if it is less than 7 or 8 to 10 or more than 11. If it is less than 7, the patient is stable and the recommended treatment with 2 potentially hepatotoxic drugs likely to be well tolerated. And we use Child-Pugh score for this, for the grading of the patient of chronic liver disease. What is drug-induced hepatitis? In tuberculosis patient with the drug-induced hepatitis, the treatment should be stopped if ALT is more than 5 times normal in the absence of symptoms and 3 times normal in the presence of symptoms. It is suggestive of hepatitis. In less serious situations, treatment can be halted till hepatic functions have returned to normal, and then either the treatment is reinstituted or any of the above regimes can be started. If the tuberculosis situation is serious enough to continue, then one of the above drug mentioned regimes should be continued. Renal failure and severe renal insufficiency. The recommended initial tuberculosis treatment regime for patients with renal failure of severe renal insufficiency is 2 months of isoniazid, rifampicin, pyrazinamide and ethambutol followed by 4 months of isoniazid and rifampicin. Isoniazid and rifampicin are eliminated by biliary excretion, so no change in dose is necessary. There is significant renal excretion of ethambutol and metabolites of pyrazinamide, and doses should therefore be adjusted. 3 times per week administration of these 2 drugs at the following doses recommended: pyrazinamide at 25 mg per kg and ethambutol 15 mg per kg. While receiving isoniazid, patients with severe renal insufficiency or failure should be given pyridoxine 10 to 20 mg in order to prevent peripheral neuropathy. Because of an increased risk of nephrotoxicity and ototoxicity, streptomycin should be avoided in patients with renal failure. If streptomycin must be continued, the dosage is 15 mg per kg 2 or 3 times per week to a maximum of 1 gram per dose, and serum levels of drug should be monitored. Ethambutol is excreted predominantly by the kidneys and should be used in the decreased dosage of 5 to 10 milligrams per kg per day or 25 mg per kg thrice or twice a week depending upon the creatinine clearance rates. Dosage of ofloxacin and other quinolones should also be reduced in CRF patients. HIV and tuberculosis. The recommended treatment of TB disease in adult infected with HIV is 6 months. Intensive phase includes isoniazid, rifampicin, pyrazinamide and ethambutol for first 2 months and a continuation phase of isoniazid and rifampicin for last 4 months.